That the effort that Alok is doing in keeping Heart India running and flourishing single-handedly is really commendable, and we are very proud of him. So the reason I requested to request Dr. Alok to give me this talk is because nowadays we are seeing a flood of investigations being done and patients being sent to us with executive health checkups, the TMTs, the CTs being done, and then you don't do a procedure in an incidentally detected lesion. You are kind of looked down upon by your peers and maybe with a little bit of doubt with the patients. At the same point of time, if you do procedures that are on lesions that are incidentally detected, then it is certainly not scientific in most of the scenarios, and certainly non-judicious and not moral to do. So, so this slide reminds me of a small anecdote that once in US I was in a meeting and we were having a discussion about what should be the ideal way to see for viability in a patient who has presented late and has occluded arteries, or we are not sure of the muscular viabilities. And as I was discussing, I've told this story to probably Dr. Akshay, is that he got a little he was a little offensive in his comments, and he said that, we have already discussed that in OAT trial, and I was a part of OAT trial, and there was a discussion that which test you should do in order to, if you have to look for viability. And his answer was that you can do any test that is available in your hospital. And that brings me to this slide, because we have to understand that each and every non-invasive methodology of testing CAD, ischemia and viability is testing different facets of cardiovascular physiology. Before angina comes, a lot of things happen in the ischemic cascade. The first change that happens in the ischemic cascade is the metabolic alterations at the level of intracellular level, at the level of mitochondria that can be picked up by PET scans. And at the same point of time, there are changes which are happening in the cell membrane integrity that can be picked by the thallium technician uptakes and things like that. And as ischemia progresses, then the changes start to happen at a more macro level, at which there is reduced myocardial perfusion, you can see, which you can of course judge by the non-invasive methodologies of perfusion scans. And then you have this first diastolic and then systolic function abnormalities and regional wall motion abnormalities, which you can pick up by stress echo or stress MRI, stress imaging for any form or whatsoever. And then you have the ECG changes which are coming up, which can be picked up by TMT. So, and then of course you will have ischemia. So in this ischemic, so it means to say that if you are testing for viability, and if you do a dobutamine stress echo, if it turns out fine, if it turns out positive, it shows viability, it is viable. But if it's not showing viability, then probably in a selected patients you can move lower down the ladder, and then we can discuss, where PET can be of use, whether it's useful or not. But what I'm saying is that using non-invasive testing as a blanket, as a common pool, as a very generic term, is not correct. And we have to find out, and we have to realize that each non-invasive testing methodology is looking at one or the other facet of myocardial ischemia. So we have a lot of tools in our armamentarium: stress echo, TMT, thallium scans, PET, CT angios, cardiac MRs. While it is definitely proven that non-invasive testing in CAD is good in symptomatic patient, firstly to detect if there is a chest pain situation, to find out if there is ischemia or not, to detect critical flow limiting lesions, and for prognosticating the disease, that which is the disease that you should be taking up based upon the high risk criteria, as you can take it up for angiogram, and probably he will benefit by revascularization. At the same point of time, there is undoubted role of non-invasive testing in post-MI situations in finding out whether the tissue is viable or not, and whether there is some degree of ischemia or not. So in a stable coronary artery disease, symptomatic individual, and in a post-MI situation, it is definitely valuable. The problem arises that when we start to use the non-invasive testing in asymptomatic individuals to detect subclinical atherosclerosis and to identify those patients who are at high risk of future events. And there, simple cardiovascular risk scoring systems that are ample of them, we have worked on them. There are the traditional risk scoring systems of WHO, Q risk scoring. A lot of risk scoring are there. Now the artificial intelligence based risk scoring systems are available. So these are the things to diagnose the high risk individual. And of course, you can add a CT calcium score, not the full CT, but a CT calcium score to the risk scoring modalities and find out which patients are at a higher risk of developing future cardiovascular events. The point is that, the fear is that we think that, the conundrum happens, the confusion starts to happen when we do not adhere to the scientific guidelines and we start to do these tests as part of executive health checkups, as part of pre-operative evaluation. We start to do these tests in an oversensitive patients who thinks that he doesn't want to die too young, so he wants to get a battery of tests done, and of course in an overzealous physician who is shooting from the hip and getting all the investigations done as part of one package or the other. And it is done predominantly to see that, of course, the patient is not symptomatic, so they are likely to see whether we have a poor prognosis in the long term or not, and that, as I said earlier, is predicted more by risk scoring parameters than by any specific test being positive or negative out of the battery of non-invasive testing. So this is again a question that I frequently ask my fellows and my residents, that tell me 3 reasons why you treat any disease. And that is a trick question because there are only 2 reasons. You should treat any disease from common cold to malignancies to cardiovascular disease to trauma only for 2 reasons. First is the symptomatic benefit, and the second is the prevention of future mortality and morbidity. If there is any third reason that comes to our mind to treat a disease, then probably we have to do some introspections and see, and I'd be happy if anyone can tell me a third reason to do that. So in an asymptomatic individual, of course the symptoms are not there. So what you are left is the prevention of future morbidity and mortality. What will a cardiovascular patient die of? He'll die of a myocardial infarction. So does the future occurrence of myocardial infarction depend on, can you detect it? Can you predict it? You can predict it by little bit by a risk scoring system in broad classification, but you cannot predict it any specific lesion to go on and becoming a infarct causing lesions, because as we see, most of the acute coronary syndromes are caused by plaque ruptures on milder lesions, and these milder lesions are plenty in so many circulations of our body, including coronary circulations, and cannot be picked up by stress testing, and nor they should be treated by percutaneous or vascular or surgical methods. Now, coming to the non-invasive testing, if you have the clinical spectrum of disease, if your preclinical assessment says that it's a low probability of developing a CAD and you still want to go ahead and do a test, then probably CT is the investigation. If you have a very high likelihood of developing of a CAD, that is to detect CAD in terms of ischemia, suppose we are talking about a situation here where there is the chest pain that you are not sure of, that it's an angina or non-angina, and then if you want to subject this patient to non-invasive testing and the patient is extremely low risk for being a CAD, like a young female less than 40 years of age, then probably CT angio is the thing to do. At the same point of time, if you are suspecting angina, whether you are sure or not by clinical methodology, and the probability of having CAD is very high. For example, he is a 60-year-old man with diabetes, hypertension, and a lot of comorbidities, then probably the right test for them is a direct coronary angiogram, and if there are intermediate lesions which you are still not sure of, you can do intracoronary physiology testing to find out whether they are significant or not. But at the same point of time, if there is an intermediate probability, then probably stress testing is supposed to be done. And in that scenario, TMT is inferior to the image-based stress testing, and image-based stress testing in terms of stress echo is supposed to be given advantage. This is the ideal situation in a utopian world, and then we'll come to the specific advantages and disadvantages of each test as we move forward in the presentation. So coronary CT angiogram, excellent anatomical diagnosis is given. particularly useful in acute coronary syndrome situation where there's an ECG and CHOP-Ts are normal, but you still want to rule out. You can do a triple rule out, because in one CT angiogram in your emergency setting, you can rule out 3 life-saving cardiovascular conditions, and that is acute myocardial infarctions. Critical stenosis of CAD, I may put it that way, because the ECG and troponins are normal, and then pulmonary embolisms and aortic dissections. Of course, the disadvantages are the cost, radiation exposure. It's cautious use, caution in renal impairment, because a lot of contrast is required, and I think that technique point of view, I think CT is now a very, very good tool, and we have very, very good images and a lot of not really a problem in the interpretations. The TMT, on the other hand, is cheap, easy to perform. We all do it in all our clinics, but we have to realize that it is a very poor sensitivity and a poor specificity test. If it's positive, yes, maybe we could. The negative test sometimes can get us into trouble, and there are many ECG changes, many baseline ECG changes, and many clinical situations where TMT either cannot be performed because the patient cannot excise that much, or the baseline ECGs of like RBBs and LBBs, the interpretation of TMT may be difficult. Stress echo, again a brilliant test. As I said, in between the stress testing in the intermediate probability of CAD conditions, stress test is superior to TMT. It is non-ionizing, simple to perform, extensive long-term data, and in terms of predicting which patients will benefit by revascularization, then probably stress echo is a very, very good tool, because it tells us a large macro wall motion abnormalities in an area which of course, if treated by percutaneous or surgical methods, respond brilliantly, rather than small patches of ischemia which may not be respond so well to the surgical and interventional treatment. Of course, disadvantages are that it is cumbersome to set up the whole thing, and it's a little time consuming in a heavy hospital, so people really go little away from it. Stress echo, we can find out both ischemia as well as viability. If there's hypokinesia or akinesia at rest, and with dobutamine it normalizes, then it shows there is viability. If it's normokinesis and it goes into hypokinesia or akinesia, it shows ischemia. And if it's a severely hypokinetic or akinetic segment, remains that way, it shows necrosis, and these patients of necrosis will not improve by therapy. Of course, biphasic response, that at low doses it actually improves, and at high doses the wall motion abnormalities go down. Then probably that is the most specific feature which shows response to therapy in terms of revascularization. These patients will respond. Of course, technetium, thallium scans, widely available. They are very good in predicting viability and ischemia. They again give us the image in the region wise, so we know which particular coronary artery, LAD region or a circumflex region, or which areas of myocardium are not performing well in terms of ischemia or viability, and then we can make our anatomical decisions of treating those arteries clearly. The problems here again are radiation. It sometimes in multi-vessel disease, because of the balanced ischemia, the interpretation of images become difficult. Again, you see the images are like short axis and long axis of your echoes. This is a normal scan, and if you see here, if you see the rest images, this is short axis, which is normal images, but the stress shows that there is a septal region, huge, anterior-septal sort of ischemia is present here. Similarly, if you combine it by a CT scan, here you see on rest everything is normal. In stress, you see these inferior wall changes happening. Inferior wall holes start to come up, and these inferior wall holes start to come up. And when you see that with angiogram, there's a critical lesion in the RCA, and therefore it needs to be treated. Of course, it can tell us about if there is reduced blood flow while as preserved function, which is called as the perfusion metabolism mismatch. That's a PET we are coming to, sorry. So we have come to PET. So PET is beautiful because it tells us about both the myocardial blood flow as well as the metabolism, if preserved or not. So if the myocardial blood flow is preserved, but the if it's reduced, sorry, and if the metabolism by the FDG uptake is preserved, metabolism mismatch and this muscle is hibernating, it can improve on therapy. But if there is no blood flow and no FDG uptake, then it's a perfusion metabolism match in negative sense. So this is a scarred territory and should not be treated. Here again you see there is a hibernating myocardium, in which you see in the rubidium scan, which is the perfusion scan, you see perfusion defects. But at the same point of time, when you see the FDG uptake, which is the metabolism is preserved. So ischemia is there, the blood supply is not there, but the muscle is still alive. Treating this muscle may help this patient recover this area of myocardium. MR is again a brilliant tool, but very infrequently available except for large institutes. It can do multiple things. It can do a stress MR, can predict anything like a stress imaging in a much better way. You can correlate with the critical coronary lesions and kind of get the same kind of picture. In some studies, it is being shown better than the perfusion scans in SPECT. And you can actually, with the late gadolinium enhancements, the amount of the thickness of myocardium that is scarred, you can pick it up. And any thickness more than 50% which is scarred, you can say that this is sort of not respond to treatment. It's sort of a scarred myocardium. So MR gives you a lot of information. I would like to, briefly for the sake of time, end here. And again, like to reinstate that point that non-invasive testing is a brilliant tools in our hand, but we have to use these tools judiciously in right clinical setting, understanding that each test is addressing different facets of coronary artery disease, and try to see why we are using this test. Are we using this test to detect whether this pain is whether pain is anginal or not? But an absolutely asymptomatic individual who has not suffered a myocardial infarction, subjecting these patients to non-invasive testing gets us many times in bigger troubles than it provides solutions. Thank you so much.
Excellent talk by Dr. Rishi in your own style. Sir, any your preferences for the single tools?
Excuse me?
Any your preferences for the non-invasive test?
No, it depends it depends why we are doing this. So I mean, if we have to detect in an outpatient, a patient comes with chest pain. It's not classically anginal chest pain, or there's some doubt about it. If it's a very young individual, if the probability of his or her coming out CAD is low, my test would be a CT angiogram. If the probability is very high, if the patient has diabetes, some degree of dyspnea that I am attributing to angina, and you have a gut feeling that the probability is going to be, gut feeling is a wrong term to use in scientific presentations, but what I'm meaning by the whole constellation of his clinical presentation is showing that there is a very high risk of developing, of having CAD, high probability of having CAD, then you can take the patient up for angiogram. Angiogram does not mean going up for PCI. Angiogram, seeing that if you do get critical disease, you treat it. If you get intermediate disease, then do FFR or whatever your preference is, and try to find out whether these lesions were responsible for this angina or not. In the intermediate condition, which is most of the time, for the want of it, I mean, TMT is the simplest thing to do, but if given a choice, then probably stress echo would be better. For post-myocardial infarction patients, where we are trying to find out whether this tissue is viable or not, we end up subjecting these patients to stress thalliums and perfusion scans. But I would say that it's going to be stepwise manner. You can do dobutamine stress. If the dobutamine stress shows viability, treat it as viability. And if the dobutamine stress is non-viability, then you can proceed to, again, the stress thalliums. In rare conditions, if the stress thallium is also not committing on the viability, and it's a young individual in which you have some other evidences, is 100% occluded proximal LAD or mid LAD, you feel that this tissue is going to be viable. And how you feel it, in your echo, your thickness is sort of a little bit preserved. There's a small little R wave here, and you know this tissue appears to be viable. And he's a young individual who's going to live with that artery for next 30-40 years. Probably in that situation is a situation that I would send them to PET, and to give them the advantage that if the PET shows that the viability is there, you can go ahead and fix it. And I'll tell you, in my clinical practice, there have been 3 to 4 such patients only.
Last question.
Sir.
Actually, most majority of the CT angiograms are reported by the radiologist.
Yeah.
So, what's your take on the sensitivity and the specificity of this? Because majority of the times they are being reported by the radiologist. They have definitely they are not probably good exposure to the coronary anatomy. So, do you have a chance of raising false alarms in these group of patients?
So that's a very important practical problem that we face every single day. Is that the radiologist is not so. The importance of a CT scan in the hands of radiologists comes when the radiologist says that it is spick and span absolutely normal. Then you trust the radiologist and you go ahead with it. If the radiologist says that if there's an intermediate degree disease or a 50% diffuse kind of disease, I would suggest first look at if possible, the hard DICOM images. If not possible, and at least the plates, the raw plates, and the raw images on the plates, not the reconstructed images. See for yourself and make a decision based upon the clinical finding and what you are seeing there, rather than just trusting the radiologist would not be in a position to comment, or they are most in many expert centers they are, but the most of the radiologists that are doing it in centers which are smaller probably will not have the assessment of the criticality of the lesion. If they say if it's negative, the negative predictive value, and that's the beauty of it.